Welcome everyone, and thank you for joining our CE webinar this afternoon, a 2 CEU presentation called An Introduction to Tourette's Syndrome with Barbara Chabner, PsyD. I am Jillian Silverman at NASW NJ, and I will be moderating the webinar this afternoon. A few housekeeping items first. If you're having any difficulties with the online or audio portion of this webinar, please make sure you've entered in your audio PIN and your computer speakers are on. Due to the number of people registered and to protect your confidentiality, attendees' phone lines will be muted. Type any questions in the GoToWebinar chat feature on the right side of the screen. We will stop at various intervals to answer any questions about the material. We will also take questions at the end of the presentation. At the very end of the webinar, I will put up a link for the post-test quiz in the chat box so you can take it tonight if you like. You'll also receive a separate email with the same link. The post-test must be completed by Tuesday, July 30th. We are recording this session, so please keep that in mind when you're asking your questions. Now I would like to turn it over to our presenter, Barbara Chabner.
Thank you. Thank you for that introduction, and thank you to everyone for sharing your lunch hour with me today to learn about Tourette's Syndrome. Okay, can everybody see? Okay, so upon completion of the webinar, I hope that you will all gain an awareness of NJCTS programs and services, have the ability to identify signs and symptoms of Tourette's syndrome and the associated disorders, understand some of the treatment options for Tourette's syndrome, and have a more holistic way of looking at the needs, stresses, and perspectives of people with Tourette's syndrome. So first I'm going to just talk for a few minutes about New Jersey Center for Tourette's Syndrome and what our programs and services are. And then I've divided the webinar into a couple of different sections. We're going to look at what Tourette's Syndrome is and what the associated disorders are. We're going to look at treatment options, and then we're going to look at some strategies for how to work with people with Tourette's syndrome in a few different settings. And I think we'll pause in between each of those sections for some questions and answers. Okay, so New Jersey Center for Tourette's Syndrome is a support and education and advocacy organization. We are not a clinical direct service organization. Just to highlight a couple of the things that we do, many of the programs that we have are education programs where we will go into schools, hospitals, different community agencies to present on Tourette's syndrome, to educate and create an awareness about what Tourette's syndrome is. We also have a webinar series about once a month on Wednesday evenings on a wide variety of topics. We have a youth development program where we encourage our youth to become youth advocates, or they can go into, we train them to go into schools to present to their peers. We also have a Leadership Academy program for high school students that's taking place next week at Rutgers University. We have a couple of collaborations with Rutgers. One of them is the TS clinic at Rutgers, which is a collaboration with GZAP, the psychology program at Rutgers, and is a training ground for psychology students in a clinic that sees people with Tourette's syndrome and the associated disorders. We have a research collaboration with Rutgers, which I will talk about a little bit later. So we have a wide variety of programs and services. We also have a physician's referral service. So if anybody is in need of a doctor, a neurologist, psychiatrist, a therapist that has some knowledge and experience about Tourette's syndrome and the associated disorders, we have a referral list. So I encourage you to just go on to our website, familiarize yourself with the programs and services, so that if you are in need, have any clients with Tourette's syndrome, you can send them to a place where they can receive some services. Okay, so let's talk about Tourette's syndrome and the associated disorders and take a look at actually what Tourette's syndrome is. So Georges Gilles de la Tourette was the first to write about what became Tourette's syndrome. So in 1884, he, as a French physician, in 1884, he wrote a paper that described 9 patients with what he identified as involuntary motor and vocal movements. And while he was not the first to necessarily identify this, he was the first to write about it, and the disorder became named after him. And these involuntary motor and vocal movements have become known as tics. Definition that we use of tics is a sudden, brief, recurrent, non-rhythmic stereotyped motor movement or vocalization which occur on a background of otherwise normal activity. So let's take a look at what that means. These are some of the motor tics. This is not an exhaustive list, but things like blinking, grimacing, head shaking, twirling, tapping, and I want to call your attention to a few others. Abdominal tensing. So it is possible to be ticking and have it not be apparent to other people. So for example, with abdominal tensing, you wouldn't necessarily see it, but that doesn't mean that it's not disruptive to the person that's experiencing it. Also like to call your attention to what we call copopraxia, and that is exhibiting obscene gestures, and that is also a motor tic. It is not terribly common, but it does occur. And then some vocal tics, sniffing, coughing, grunting, throat clearing is a fairly common one. And then I'd like to call your attention to a few others: echolalia, which is repeating others, palilalia, which is repeating oneself, and then coprolalia, which is the shouting out of, typically the shouting out of obscenities or inappropriate language, and that typically takes the form of obscenities or possibly racial slurs or other inappropriate language. If you've seen Tourette syndrome portrayed in the movies or TV, typically they show someone with coprolalia because it's kind of attention-getting. However, only about 10% of people that have Tourette syndrome have coprolalia, and it is not necessary for a diagnosis of Tourette syndrome. We divide tics into simple and complex, also based around the kind of musculature that's involved in the tic. Okay, some characteristics of tics. They are involuntary, although I have heard some people refer to them as semi-voluntary because there is, for some people, the ability to temporarily suppress them. However, they're really not volitional, and so they really are involuntary. They tend to wax and wane and change in both the type, the intensity, location, and severity. They are, as I said, often divided into simple and complex. They can increase with stress, excitement, fatigue. Almost any kind of environmental situation can exacerbate tics. They are sometimes, for some people, temporarily suppressible, but there's a consequence if you're going to suppress them. So if you think about a child in a classroom, for example, that doesn't want to tic because they don't want to disturb the class, they're holding in the tic, and they're probably not paying attention to what's going on in the classroom, to the teacher. So for those that try to suppress the tics, some can do it, but there's a consequence of doing so. And we also know that tics may be reduced when people are engaged in a very focused activities. So if anybody is out there is a knowledgeable about soccer and knows of Tim Howard, who is a soccer player, a goalie, he plays, he at one point played overseas in England. He now plays in Colorado, and he has Tourette syndrome. When he is on the field defending the goal, his tics seem to be reduced or not present. When he's off the field, he does still tic. So and many of our kids that we work with tend to be involved in athletics, in theater, or in music, and they all kind of anecdotally report that when they're engaged in these activities in a very focused way, their tics seem to be reduced. We're not quite sure why that happens, but it does seem to be the case. Often tics are preceded by what we refer to as a premonitory urge, or a sort of anticipatory sensation, some kind of somatic or sensory experience that precedes the tic and lets the person know that the tic is about to happen. And then following that, it often creates a kind of discomfort, so a kind of anxiety or uncomfortable feeling, and that feeling is then relieved by engaging in the tic. So it's a bit of a cycle where there is this anticipatory sensation, there is an anxiety or discomfort, there's the tic, and then there is relief. these sensations occur about 80% of the time. So not always for every person with every tic, but about 80% of the time. So the diagnostic criteria, tics, Tourette syndrome is in the DSM. It is considered a neurobiological disorder. It's characterized as a motor disorder under the category of neurodevelopmental disorders. Multiple motor and one or more vocal tic is necessary to meet the diagnostic criteria. They do not have to occur simultaneously. And the occurrence of tics has to occur many times a day, nearly every day, or intermittently throughout a span of more than 1 year. So it has to occur for more than a year in order to meet the criteria for diagnosis. And as I mentioned earlier, tics may wax and wane. They can change in number and frequency, location, and severity. They can even disappear for days, weeks, or even a couple of months at a time. But during the course of that span of more than 1 year, they have to be present more than not. And then onset is before the age of 18. We do get calls sometimes from people, adults or young adults, that say they've had tics all their lives, but they were not identified as such, and they were only recently diagnosed officially. But the onset of the tics needs to be before age 18. And then, as is found in all the other DSM diagnoses, the tics are not due to some other a cause, some other physiological effects of a substance or other medical condition. Now, there are also a couple of other tic disorders that don't meet the full criteria for Tourette's syndrome. One is persistent motor or vocal tic disorder. And for this, one or more motor or vocal tics is necessary, but not both. And again, tics occur many times a day, almost every day, or on and off, throughout a period of more than 1 year. And again, onset is before age 18. And there is one additional tic disorder, provisional, or used to be referred to as transient tic disorder. And this is where there is one or more motor or vocal tic, and it's present for less than 12 months. And after that, it will go away. And again, the onset is before age 18. In terms of what causes Tourette's syndrome, it's really not clear. We don't know yet. The disorder is probably caused by some abnormal metabolic activity of one of the neurotransmitters. Likely dopamine and serotonin is involved, particularly dopamine, which we know is also involved in Parkinson's, which is also another movement disorder. So there is research that is looking at that. In terms of the brain areas, the basal ganglia, which is involved with movement, and the frontal cortex are areas that may be implicated in Tourette's syndrome. There have been some recent research breakthroughs, and I will talk about that on the next slide. And then there is no medical test to prove or disprove the presence of Tourette's syndrome. It is diagnosed through assessment, which I will talk about a little bit further in the presentation. So one of the other things that NJCTS is involved in is another collaboration with Rutgers, and that is the DNA and cell sharing repository. This was established in 2007, and it allowed for people who have Tourette's syndrome to participate in research by giving a blood draw and filling out some extensive background paperwork and information, and then the blood work was sent to the cell sharing repository, where it is cleaned up and prepped, and then is ready to be used for somebody that wants to do research on Tourette's syndrome. And in 2011, the TIC International Collaborative Genetic Study, or TIC Genetics, was established, and that was the NIMH awarded a grant to Rutgers to further develop the DNA and cell sharing repository. So instead of just being a collection site at Rutgers, there are now 26 collection sites throughout world where people can participate in this blood draw, completing the patient sent to Rutgers. And again, the material gets prepared and is ready for somebody that wants to do research on Tourette's syndrome. And over the last couple of years, there have been a couple of significant research papers. So in May of 2017 and September of 2018, there were some discoveries related to some of the genes that are believed to be involved with Tourette's syndrome. So it is now understood that it is caused through some kind of mutant or damaged genes. There's been the identification of several high conflict TS risk genes, and it is now estimated that approximately 400 genes could pose a risk for TS when damaged or mutated. So again, it is a multigenetic disorder. And as a result of these breakthroughs, the NIMH awarded a $10 million grant for continued research. So we are very hopeful. In the last couple of years, there have been these significant breakthroughs, and we're very hopeful that, that there will continue to be some breakthroughs in understanding what causes Tourette's syndrome, which of course will then help to direct ourselves to treatments. Okay, we often refer to Tourette's syndrome as a misunderstood and misdiagnosed disorder because many people are not aware of what it is, what it looks like, and it's often mistaken for other things. So for example, if you have somebody who has a throat clearing tic or somebody that has a face grimacing or eye blinking tic, those are all things that might be considered to be either allergies or some kind of eye problem. So oftentimes when some of the tics are present, people attribute them to other problems and may take somebody to an ophthalmologist or to an allergist to look at these things. Also, sometimes these symptoms are seen as attention-seeking behaviors, and also sometimes people assume that coprolalia is necessary for a diagnosis, which, as I said earlier, it is not. And all of these factors sometimes contribute to a delay in diagnosis, as well as the fact that people are just not aware of what Tourette syndrome looks like. So approximately 1 in 100 children show signs of Tourette syndrome. Males are more likely to have Tourette syndrome than females, and we do know that it affects all races and ethnic groups. So some of the characteristics of Tourette syndrome. Tics appear around ages 5 to 7. They often begin with a motor tic of the head or neck. So they typically begin sort of from the shoulders up. So you might see things like the facial tics, the grimacing, the eye blinking, or the throat clearing, those kinds of things first. And then other tics will develop in other areas, locations of the body. Tics tend to peak between ages 8 to 12, and they frequently diminish by late adolescence and early adulthood. That said, we find that in adolescence, sometimes people have, very severe tics, and we also find in adulthood that there are a percentage of adults with Tourette syndrome for whom the tics do not diminish. It is considered a spectrum disorder, so it can be identified as mild, moderate, or severe. And it is considered to be a lifelong disorder. So even for adults who have no clear manifestation of tics, and adults for whom the tics have diminished, it is considered still to be a lifelong disorder. There is no medical test, there is no blood test, there is no scan, no x-ray. Diagnosis is really by assessment by someone who is knowledgeable of what Tourette syndrome is and what it looks like. Typically that's a neurologist. If a pediatrician is aware, if a psychiatrist or a therapist is aware, they can make the diagnosis as well, but it is typically made by a neurologist as it is a movement disorder. There is no standard treatment protocol, and every presentation is unique. So the symptoms vary from person to person. There is really no typical case. So if everybody who is on this webinar had Tourette syndrome, it would all look very different. You would all have your own kind of unique combination of tics and potentially comorbid disorders, which I'll talk about a little bit later. And as you can imagine, Tourette syndrome really can impact functioning in all spheres. So it can affect functioning in the social, emotional, academic, and occupational areas of one's life. And this is just a graphic here to indicate some of the environmental factors that can impact Tourette syndrome and exacerbate the tics. And as I said earlier, almost anything environmentally can exacerbate it, and that's why it's very important when you're working with someone with Tourette syndrome to help them to identify what their environmental triggers are. And it's important to note as well that it can be something positive, so it doesn't have to just be a negative stressor. For example, if somebody is going on vacation and they're very excited about going on vacation, that could exacerbate the tics as well. We often refer to tics as being just the tip of the iceberg because while it is possible to have a diagnosis only of Tourette syndrome, the majority of the people that have Tourette syndrome also have some other comorbid disorders. Many of them you see on this graphic. So attention deficit hyperactivity disorder, ADHD, and obsessive compulsive disorder, OCD, are two of the highest percentage comorbid disorders, but there are others as well. So approximately 86% of children diagnosed with Tourette syndrome are also diagnosed with at least one mental health, behavioral, or developmental condition. And as I mentioned, ADHD and OCD are two of the most common comorbid disorders. We also see anxiety disorders, some impulse control disorders, some social skills deficits at times, and some learning disorders. And I will speak about ADHD and OCD a little bit more, and then I will mention some of the others as well. So again, here is just a graphic to kind of help you see again some of the comorbid disorders that frequently accompany Tourette syndrome. And if you think about what I just mentioned in terms of the characteristics of Tourette syndrome, and now going forward, we're going to talk a little bit about ADHD and OCD, think about layering ADHD and OCD on top of Tourette syndrome, and it gives you really a picture of how complicated this can be and how it can really impair functioning if things are not managed and addressed. We like to sometimes talk about the triad of ADHD, OCD, and Tourette syndrome. And so most of you are probably familiar with OCD, obsessive compulsive disorder, and the obsessive compulsive disorder sort of cycle, as you see in the graphic here, is similar in some ways to that I mentioned regarding Tourette syndrome. So we have the obsessions or the intrusive and recurring thoughts or impulses that our mind tends to get stuck on. It creates an unpleasant experience and kind of disrupts our functioning. It creates an anxiety. That anxiety is relieved by compulsions or behaviors that we do in a ritualistic manner typically, and that provides relief. So that is a sort of a similar cycle as the cycle of premonitory urge, discomfort, tic, and relief. And as you can see on this slide, again, I've noted that OCD and TS share some characteristics, and that sort of cycle is one of them. We sometimes refer to OCD and as tics of the mind, and both, again, have that sort of waxing and waning quality. We can also refer to sort of Tourettic OCD, sort of just right for the person, and that might result in tics such as tapping or touching things or counting in a certain way, mental list making. So some of the OCD things that we see that have that sort of just right quality to them. And in terms of the OCD and TS compounding each other, it's not uncommon for OCD to link with a TS tic, and now the tic needs to be done in a certain way or a certain number of times. For example, if I had a tic that involved shooting my right arm out to the side, I might have to do it 3 times, and then I might have to do it 3 times on the left side as well. Okay. And again, TS and OCD can present some complications in school, difficulty in transitioning from one activity to the next, the wish to touch things that are off limits, the whole notion of sort of the perfectionistic component that goes along with OCD sometimes can interfere with getting started on tasks, with completing tasks, and struggling to kind of move on from one thing to the next and make transitions. TS and ADHD. Again, a large number of students with TS also have ADHD, and some of the things you're probably familiar with ADHD, some of the things that we can see sometimes are that hyperactivity, the poor impulse control, the poor concentration, and the sense of being easily distracted. Sometimes there is a social immaturity and proneness to rages and to frustration. And again, the manifestation in school of TS and ADHD can present some complications in terms of inattention, impulsivity, disorganization, many of the things, again, that you're probably aware of that we see with Tourette's and with ADHD. Difficulty sitting still for long periods of time. And so again, if you can imagine having TS compounded by ADHD, compounded by OCD, it can become very challenging for kids in school. Okay, we also do see some learning disabilities. About 40% of individuals who have TS have some kind of learning disability. And it is important to note, though, that most people with Tourette's syndrome exhibit average to above average intelligence. So it is not an intelligence issue. And again, TS and learning disabilities, sometimes people have issues in terms of following directions, processing abstract information, following conversations. People may be easily distracted by noise in the environment. There may be slower processing speeds, difficulty with auditory discrimination. One of the things that we see frequently is something called dysgraphia, and this is not just sort of poor, difficult to read handwriting, but it really speaks to written expression in the written form. So someone might be able to communicate something verbally, but then when it comes down to time to writing it, there might be difficulty in that written expression. So this can again present difficulties in school for kids in terms of taking notes, in terms of copying correctly from instructions from the board, or copying something from a book to the paper can become very difficult and challenging for them. And then we can talk about executive function. So again, you may be familiar with executive function, which are sort of brain processes that guide thought and behavior. They're brain processes that really help us to be able to engage in goal-directed behavior. And they are common. Having executive function challenges is common in ADHD and TS. Again, it is not an IQ problem. It is more a problem from being able to sort of organize yourself and plan. So it can interfere with organizing, with, again, transitioning from one thing to a next, with sequencing activities. So if somebody, if a teacher puts an assignment on the board and puts it in several steps to the assignment, somebody with executive function challenges might have difficulty in following those sequences, getting them in the right order, or prioritizing them. And again, we see a good percentage of people with Tourette's syndrome having some kind of executive function challenges. There are also some sensory issues that we see that can affect any of the senses that cause anxiety for many children with Tourette's syndrome. So there may be some sensitivities to touch, to texture. So that would be the example of clothing, the label in the back of the shirt, or sometimes the seam of the sock that people are sensitive to. Light, they may be sensitive to, and sounds. And difficulty in overstimulating environments and kind of managing environments where there is a lot going on. Okay. We also, as I noted earlier, sometimes see some social skills deficits. So some challenges when interacting with peers, not necessarily perceiving emotions and those social cues, having difficulty perceiving those emotions and social cues. They may demonstrate a lack of judgment, may prefer to engage in independent activities rather than in group activities, rather than engaging with other kids. And then there is something that is known as pediatric autoimmune neuropsychiatric disorders associated with streptococcal infections, or otherwise known as PANDAS. Now, this is a diagnosis that is controversial. Not everybody agrees upon it. It is understood to be the rapid onset of OCD or tic disorder symptoms that result from some kind of immune system overreactivity to infection. And that infection is typically a strep infection. So for those that agree with and go by this diagnosis, they will often suggest that it has occurred in someone after they have had multiple strep infections. It is a pediatric onset. The course is sudden and severe. And again, for those that have identified it, have treated it with cognitive behavioral therapy and SSRI medications have deemed to be effective treatments. Okay, so I'd like to pause here before we move into talking about treatment, see if there are any questions about Tourette's syndrome and the associated disorders as I've mentioned them. No questions?
We have one question.
Okay.
And it's regarding how you would distinguish TS from OCD, and if it's because OCD involves a thought and compulsion versus TS having involuntary motor movements.
Basically, yes. So they share some characteristics, as I said, in terms of the waxing and waning, and in terms of the cycle of obsession, discomfort, compulsion, relief, and premonitory sensation, tic, discomfort, tic, and relief. But the OCD symptoms are, you know, the compulsions, the obsessions and the compulsions are not tics, right? And the tics are identified as and defined as those motor and vocal movements. So while there are some shared experiences, that really does define the difference.
Okay, great. Thank you. One more question. You went over a slide about the senses and mentioned sensory tics.
Yes.
Are those just in reaction to the stimulus?
There can be reaction to the stimulus. Also, people can get sometimes a little bit of a sensory experience. So it could be kind of a tingling sensation in the arm, or it could be a kind of a little bit of a warming feeling on the shoulder or the neck that are kind of, they're not tics in the traditional definition of a motor or vocal movement, but they are experienced in that same kind of way. That kind of it can be repetitive, and they can kind of come and go and wax and wane. And
one more follow-up to that.
Sure.
The question is about having a precursor or an aura, maybe before a tic comes on.
That would be the premonitory urge, or that sort of anticipatory sensory experience that would indicate. So that would indicate that a tic is coming. So an example might be, again, sometimes people experience it as a sort of a tingling in the arm that's telling them that they need to tic. I would liken it to almost that sensation that we sometimes get, that sort of tickle in our nose that we get sometimes when we feel like a sneeze is coming on. So it's that sort of thing that it kind of indicates, it's a little bit of some kind of sensory experience that indicates the need to tic. And if you don't tic, then there's a discomfort that's created, kind of an anxiety and a discomfort, which is not relieved until you actually tic.
Thank you. I'm not sure if you're going to get into this in the next segment, but what are your thoughts on stimulants such as Ritalin bringing out tics?
Okay, so we'll talk a little bit about medication in the next section in treatment. I won't speak to Ritalin specifically, but we will address sort of the medication piece.
All right, great, thank you. So that's the questions for this part.
Okay, sure, then I'll continue. We'll talk a little bit about treatment of Tourette's syndrome. So when we talk about treatment, we're really talking about management of tics. There is no cure. As I mentioned earlier, there's no standard protocol or sort of singular treatment. So we're talking about things that are really meant to kind of lessen the tics, lessen the intensity or frequency of them, or help people manage the tics. And I've divided it up into 3 basic categories, one being medication treatments, another being what I've defined as more traditional therapies, and then a third being what I've defined as non-traditional treatments. So first of all, we can talk about Tourette's syndrome and medication. First thing that's important to remember to be very careful and very thoughtful about using any of these kind of medications. And of course, the antipsychotic medications have some significant side effects. The antihypertensive medications, some of them also can be used for tics. 10X or guanfacine is one that is used fairly frequently, and there is some indication that it can have both a positive or main effect on both tics and ADHD. And in regard to the question earlier, I can't speak specifically to Ritalin, but I can say that it is, important to be careful when treating one aspect to make sure that you understand the other aspect. So if you're really looking to manage the tics with medication, and you have other comorbid disorders, that it's important to recognize the potential impact that the medication could have on the comorbids and vice versa, as I suggested earlier. In terms of non-medical options, there are more traditional therapies, some traditional psychological treatments and counseling that can be helpful in a number of ways. Can be helpful for tic management. They can be helpful for addressing the comorbid disorders. It can also help people address the psychological stressors that accompany with TS. So you may not even necessarily be addressing the tics themselves, but what are sort of the emotional and psychological stressors that come along with having Tourette's syndrome? That's something that you might address in a more traditional therapy. Social skills training. In fact, the TS clinic at Rutgers offers every winter I believe it's a 10-session social skills training for kids. So that can be an important aspect of treatment. And it's important also, particularly when you're talking with children, as it always is, to work with the families as well and to monitor their functioning and tic behaviors. So these are some of the areas that more traditional treatments can be helpful for. There is cognitive behavioral therapy, which most of you are probably familiar with. Exposure and response prevention, which has been determined to be an effective treatment for OCD, for managing the obsessions and compulsions of OCD. And then there is something called habit reversal therapy and comprehensive behavioral intervention for tics, or CBIT. These are treatments that have been developed really very purposefully to help people manage their tics, and I'm going to talk about them a little bit more. So habit reversal is really now sort of a part of this broader comprehensive behavioral intervention for tics. It's a multi-component treatment that's used, again, to manage tics. So none of these treatments are going to completely take away the tics, but they will help people manage them in a variety of different ways. So they might reduce the intensity or frequency of them. And in the case of CBIT, essentially what it tries to do is sort of help you manage a tic by kind of changing that tic into a behavior that is more comfortable, less disruptive, less socially unacceptable. So there are three basic components to CBIT. One is awareness training, and this is where you want to help the person to become aware of their environment and their environmental triggers, and you want to help them become aware of their premonitory urges, or that sort of anticipatory sensation that's going to tell them that they need to tic. So it's working with the person to try to create this kind of awareness is the first step, and then the next step is working with them on a competing response training. So we want to then help them to engage in some kind of behavior or competing response which is incompatible with the tic. So for example, we had a young man that did some presentations for us and worked with us, and he talked about how CBIT helped him in managing his tics. He had a tic that he would shoot his arm out to the side, and he would do it pretty forcefully and with pretty good frequency. And he was always concerned that he would hit someone that might be standing or sitting next to him. So in his CBIT training, they taught him to, when he had that urge, when he had that sensation to engage in that tic, he would put his hands in his pockets and he would keep them there. And you have to, again, kind of ride out that sensation. But eventually you sort of become, through the training, you become more habituated to it, and you can kind of ride it out so that you don't have to engage in the tic, which would be a little bit more disruptive than keeping your hands in your pocket. Another example might be somebody that has a throat clearing tic. They might teach them to do a deep breathing, diaphragmatic breathing, which is kind of incompatible with clearing your throat. So the idea, again, is to try to kind of help the person engage in a behavior which is incompatible with the tic, but is a behavior that is a little bit less disruptive or a little bit less problematic in one way or another than the tic itself. And then the last main component to the treatment is managing one's environment. Again, sort of identifying what those triggers are, those environmental triggers are, and trying to create the environment in such a way as to reduce those triggers, and as well to have social support, family, friends, etc. Now, there is a treatment protocol, so people, therapists need to be trained in order to deliver CBIT, in order to work with someone using CBIT. And for people, it's about an 8 to 10 session treatment, but it does involve some homework and some work at home in terms of trying to use the competing response training. And because of the competing response training and the awareness training, although some people say they have used CBIT with kids younger than 8, it's typically not recommended for children younger than 8 years old, because developmentally they just may not be capable of engaging in the awareness training and the competing response training and really being able to make full use of it. But this is a training, as I said, or treatment, which was developed really specifically to help people manage tics. Okay. We also have something called the Yale Global Tic Severity Scale. This is not a treatment, but it is an assessment. So it is a semi-structured tic assessment that looks at current and past tics, identifies them on a number of dimensions, and then it comes out with an impairment rating. So this really is used to help people kind of understand a little bit more about their tics and the degree to which the tics interfere for them, and then that information then can be used when trying to kind of design and develop a particular route of treatment for the person. And then we have what I'm referring to as sort of non-traditional treatments. We have under the category of meditation and relaxation, things like progressive muscle relaxation, diaphragmatic breathing, yoga, visualization exercises. And again, these are not treatments that actually will sort of take away the tics, but some people find them to be helpful to, at least for a short time, help them kind of reduce the tics and release stress. These are not approaches that have any kind of long-term impact, but it's really more for kind of a short-term impact. They don't work for everybody. For example, a few years ago in our Leadership Academy, which I mentioned earlier, which is a program for high school students, takes place the beginning of August for 4 days at Rutgers. We brought in a yoga instructor. We wanted to try to do a study and see if yoga was helpful for people. And we had a couple of yoga sessions, and only about half, we had about 45 people with Tourette's syndrome there, and only about half of them were able to actually be in the room when they were doing yoga. The rest of the people actually found it more anxiety producing and were not able to sort of quiet themselves to be able to engage in the yoga. So these things are very, very individual in terms of their effectiveness and in terms of people's ability to use them to help in managing their tics and their stress. We also have Botox, which is an off-label use of Botox. There is not a lot of research, but I believe there are beginning to be some studies, and there is some anecdotal evidence to suggest that the use of Botox can help to reduce tics. Now, Botox is a localized treatment that only lasts for a certain period of time, so it can be used in a very localized area to try to manage a very specific particular tic that happens in in an arm or a leg, something like that. Again, it is. We don't have a lot of information, but we do have some anecdotal information to suggest that the Botox is being used or can be used in a very localized way to address a particular tic. There is also deep brain stimulation, which is the use of implantable electrodes to alter brain activity and kind of neuromodulates the sort of abnormal communication that might occur in the brain. This is really reserved for very severe cases that have been resistant to any other kind of attempts to manage tics. And again, there is some research, not a lot, but what there is suggests that it is a little bit more effective for motor tics than for vocal tics. And then just to note that medical marijuana is now on the acceptable use list for as a treatment, something that can be used for Tourette's syndrome. And again, there is not a tremendous amount of research, but we are seeing some anecdotal evidence to suggest that it can be helpful for some people to help them manage their tics. Marijuana, deep brain stimulation, more particularly recommended for adults, but they are there is some evidence to suggest that they may be helpful treatments. And then things like diet and sleep, also very important. General sort of good hygiene and taking care of oneself are very important as well. We know that when people are tired and overtired, that's certainly the possibility to kind of exacerbate tics. In terms of diet, again, there is limited research, but we've worked with families where their children with Tourette's syndrome have really altered their diet by taking out gluten, taking out dyes, taking out sugar, and have found it to be effective. So again, there's sort of limited research on that, but a lot of people anecdotally have suggested that making alterations to their diet has helped to reduce their tics. And then, of course, school and classroom modifications for kids, and we will talk about that a little bit further in the next section. So very recently, May of this year, the American Academy of Neurology came out with some treatment guidelines. And basically, it's pretty much all of the things that I've just said in terms of treatments for Tourette syndrome. So the things that many of us have been saying for quite a while is actually kind of what they have determined are really the best ways to approach treating Tourette syndrome. From education, spreading education to the family, to the school, what it is and what it looks like, so that they understand the tics as tics and not as some kind of other manifestation of some other issue. They also recommend what they refer to as watchful waiting. So again, if there is not a high level of distress or impairment from the tics, they recommend actually kind of waiting before jumping into any kind of treatment to see what the course of the tics is, whether they seem to be mild or more severe. We do know that sometimes symptoms improve in late adolescence, so they do recommend, rather than kind of jumping into treatment immediately, doing that, what they refer to as watchful waiting, keeping an eye on it, and at some point, if it becomes more distressing, more impairing, then moving into a treatment. The Academy has identified CBIT as the first choice treatment if you are looking to do some kind of treatment to manage your tics. They suggest, again, assessing for the comorbid disorders, medicating those if necessary, but again, medication as a more of a not a first-line treatment, where possible. And again, just to reiterate what I said earlier, and that is that it is important to identify with the person the specific issues that are more impactful for them. So if it's the comorbid, then that is what you would focus on. If it's the TS, then that is what you would focus more on. And then for adults with severe tics that have been resistant to any other treatments, they're suggesting trying DBS, or the deep brain stimulation. And again, adults trying the medical marijuana. Now, we do also have some instances where you've heard of kids trying the medical marijuana. and having it being effective. But of course, you need to be very careful with that. And as with all treatments for anything really, the treatments do require monitoring so that people are paying attention to, to the impact of the treatments. Okay, so let's take another break here. See if there are any questions related to the treatment or anything else that I've said, and then we'll go on to some strategies for working with people with Tourette syndrome.
We have one question.
Okay.
Could you give an example of habit reversal or CBIT for eye blinking?
For eye blinking. I'd have to think about that for a moment. What comes to mind is sort of kind of an intuitive, but I'd have to think about this, would be, really having them kind of focusing in a very wide open, eyes wide open kind of way. I don't know if that would be effective or not. So I'd have to actually give that some more thought. I can sort of get back to you on that. And see if what we can come up with.
Okay, well, thank you. And I don't think we have any more questions for this section.
Okay, then we can move on, talk a little bit more about strategies for working with people with TS.
All right, great.
And I'm going to address this in a couple of different settings. So I don't know what setting all of you work in, probably a variety of different settings. I'm going to talk a little bit more about school. I'll talk a little bit about working with people in the workplace. We'll talk a little bit about engaging with law enforcement. And then I think we'll wrap it up. So we can go back to talking about Tourette syndrome in schools. Again, we go back to education being very significant, informing the teacher, informing the administration, and having some kind of communication between home and the school about any medication changes, about a change in tics, about anything in the child's environment and their day-to-day lives that may have changed that could affect their symptoms. It's also important to be mindful of HIB, the harassment, intimidation, and bullying. Kids that have Tourette syndrome are often subject to teasing, to shaming, to being made fun of, because people don't understand what they're doing and why they're engaging in what looks like sometimes to be these odd behaviors. And that's why when we go into schools and have our teenagers with Tourette syndrome go in and speak to kids in the schools, it's really pretty effective. It gives the kids a better understanding when somebody says to them, my brain works a little bit differently and this is why I do this. And then kids tend to be a little bit more understanding and respectful. But kids with TS are subject often to HIB incidents. It's important to be mindful of them, to identify them as such when they meet the criteria, and also to model anti-bullying behavior in the classroom and the school and create a positive class environment and a positive classroom climate. So even tics that appear mild might actually be disruptive and distracting. And sometimes it's the ones that don't seem to be that difficult or that intense that could be the most distracting. So for example, a child in a classroom that does have an eye blinking tic, that can interfere pretty much with reading, with doing their work. We can't assume that a tic is not disruptive. And even as I noted earlier, that it's possible to have a tic that is not visible, but doesn't mean that it's not disruptive and distracting to the person that is experiencing it. Some tics might interfere with classroom performance and might interfere with sort of the flow of the class. Again, kids with Tourette syndrome don't want a tic. They are sometimes embarrassed. Sometimes they have trouble making friends, again, because they engage in these behaviors which people think are odd. Sometimes kids are jealous about the accommodations that other kids get when they need them, which further subjects them to bullying and shaming and intimidation. So what are some of the things that can be done in the classroom? You can seat the student with TS in an area where tics will be less noticeable and less embarrassing. So perhaps that's the back of the class, perhaps that's the front of the class, whatever it is in terms of how that particular classroom is set up. But being cognizant in some way of letting the child sit in an area where the tics will be less problematic. Allow the student to leave class early to avoid sort of the crowded hallways, that overstimulation that comes in that transition between classroom time. We also suggest kind of having the child find an ally in the school. Often that is the nurse. Sometimes it could be the school social worker or the school psychologist, somebody else on the child study team, but someone that kind of understands Tourette's syndrome and can sort of be an ally for the child in the school. And we suggest trying to find a place of refuge where the student can calm down, go to release their tics if needed. So allowing the child the ability to step out of class when they feel that they're going to have a lot of tics, or that they feel that they need to, they can use it throughout the day. They can go perhaps to the school nurse's office and just rest, sit down, relax for a few minutes, calm down, and then go back into the classroom. So we do recommend, as I said, trying to find sort of an ally in the school for the child. We have had a number of people tell us about Skyping into the classroom. So in this case, this would be if the child seems to be in a stage where they're ticking too much and it's disruptive to the classroom, they can go with an aide to another classroom and Skype into the classroom so they are able to participate in the lesson, but they're not disrupting the classroom. Use of different organizational aids, so color coding things, different kinds of folders. There's all sorts of technology these days that can help in kind of organizing oneself. Possibly letting the child take tests in a separate location, possibly waiving the time limits, and giving them some extended time. And then one thing that's really important, again, is to help kids sort of become empowered to stand up for themselves, to advocate for themselves, and to know that it's okay to need the accommodations, and to know that it's okay to tic when they have to. So if you're working with these students, really helping them to embrace their TS and learn to become an advocate is very important for them. Some other areas that can be helpful in school, having the teacher initial the homework assignment to make sure it's written down correctly. We talked about dysgraphia, we talked about sometimes the auditory processing, the visual processing, so kids may have trouble if a written assignment on the board, writing it down in their notebook. So checking with the teacher, asking the student to check with the teacher to make sure they've written it down correctly and that they understand the assignment. Letting the student have an extra set of textbooks at home, and I know sometimes now this is done in schools that kids might have a book in the classroom and then a book at home. Again, reducing the amount of homework. So if someone has 50 math problems, maybe letting them do 25 instead. And again, paying attention. It might vary from day to day. So on one day for a particular child, the use of the computer might be helpful, but the next day they might be having a completely different ticking experience, and that might not work for them. So giving them some choices and some options, and allowing them to do things like, for example, using a computer if that is more helpful for them at any given time. And again, you want to assess the interference of an individual tic. So the mildest tics sometimes are the most disruptive, as they use the example of eye blinking, head shaking. Those are really difficult tics when you're trying to read or write, and might require the child to have a little bit of assistance in that arena. Things like a tapping tic, which sometimes kids have. You can tape a sponge to the desk and they can tap on the sponge, which makes a lot less noise than tapping directly on the desk. We had an example of a teacher that had a child in their class that had a tic where they said peanut butter. And as you can imagine, if a child is saying peanut butter in the middle of a teacher's lesson, it can be a little bit disruptive. The kids are likely to laugh, and it can be a little disruptive. So the teacher was very creative and told the class, when the child says peanut butter, the class was to respond with jelly. This was a good technique to have that tic be a little bit less disruptive. So the child said peanut butter, the class said jelly, and then they could just kind of continue on with their lesson. So a lot of it is really being creative and flexible in terms of trying to find accommodations that can work for the given student at a given time. And again, it's important to recognize that it's not a one-size-fits-all kind of approach, because of the unique nature of Tourette's syndrome and the fact that everybody's combination of tics and comorbids looks a little bit different. It really does require accommodations that are very specific to that person. Okay, and for children who are a little bit older, not everybody has an IEP or 504 plan, but if they do, it's important to include the student in the meeting. The student often, sometimes they may have trouble identifying or articulating it, but the student often can really kind of give you the best information about what they feel is helpful for them and what they feel would be an appropriate and helpful accommodation. So where possible, it's important to include them in the planning meetings. It's important not to tell a child to stop ticking, and to not include the reduction in tics as a benchmark or a goal in any kind of plan. We don't want to tell kids or adults who are ticking to stop ticking. They need to tick. We want to give them the the flexibility to, again, step out of the classroom or maybe go someplace if they need to calm down, but we don't want to make a goal to reduce their tics. And then it's important, if you're in a school environment and you know that there's a child with Tourette's syndrome in a classroom, and you know that a substitute teacher is coming in, it's very helpful to inform that substitute in advance so that they understand what the behaviors are that child may be engaging in. Okay, Tourette's syndrome in the workplace. So an important issue, of course, is disclosing versus not disclosing. And this, again, is a very, very individual decision. A lot of people are concerned that if they disclose, they will be in some way discriminated against or judged, and that it could affect their ability to do their job, or it could affect how people view them and view their ability to do their job. On the other hand, if you are someone that feels that it would be helpful to have certain accommodations, then you're going to need to disclose. So it is a very individual and kind of personal decision in terms of disclosing or not disclosing your disorder. And of course, this may also depend on the types of tics, the severity of the tics. If you are on the kind of mild end of the spectrum, maybe it's something that you feel that nobody would notice and you don't need to say anything and you don't need any kind of accommodation. If it's something that's a little bit more severe or more noticeable, you might want to say something. People have all different kinds of ways of approaching this, and so it's, again, a very individual kind of decision, but it is important to understand your rights to accommodation. And please note that TS is included in the ADA, the Americans with Disability Act. So for addressing anxiety in the workplace, some of the accommodations can be trying to provide a quiet place or an area where the person can work alone, away from colleagues. Can set up a signal for leaving the room when their anxiety builds up and they feel they need to step out. Some places will allow the presence of a support animal, and referring to employee assistance programs if necessary, allowing for flexible breaks. In terms of concentration in the workplace for people who are easily distracted by noise, and again, it depends on kind of the work environment. It depends if somebody, if it's a small office, if everybody has their own office, if it's a big space with people just kind of working at, desks next to each other. So it's going to, the kind of combination is going to depend on the needs of the person and the actual environment of the workplace. But some other things that can be done can be to have noise canceling machines, have the person work, let them work with noise canceling headphones on, put up sound absorption panels using the kind of white noise machines in the background. Having their office space in a place that is away from auditory and visual distractions, putting up cubicle walls instead of having the sort of cubby area be more open. If you put up some enclosures that can kind of keep some of the stimulation at bay, reducing the clutter, and overall redesigning the office in such a way as to kind of minimize some of the distractions that might be present for people. In terms of organization, again, we said that people with Tourette's Syndrome, with ADHD, with OCD often have some executive function challenges in terms of kind of organizing themselves and being able to sort of follow directions and follow sequences. So there are a number of suggestions to accommodate that. It can be color-coded systems for filing and projects and activities, making a daily checklist. And some of these are just good practices anyway, but they can be particularly helpful for people that come in with some of these challenges. There are a lot of assistive technologies today, different kinds of apps and digital organizers that can help people with some of these challenges. And then having somebody, a supervisor, colleague, monitor their progress and kind of assess it frequently to make sure that the person is sort of on track with where they are supposed to be. Possibly assigning a mentor to the person so that they can, again, kind of have somebody to check in with and work with closely so that they can monitor progress and make sure that they are on track. Have the supervisor or somebody that they report to help in terms of prioritizing tasks. One of the things that we said was that sometimes people may not be able to sort of follow the sequence of tasks and steps and may have trouble prioritizing which of those steps and tasks should be done first. So having somebody work with the person to make those priorities, and breaking up long-term projects into sequential steps. Again, recognizing that somebody may need help in guiding them through the steps. You want to make sure that you're going to kind of number and sequence the steps, and you want to make sure that you touch base with the person on making sure that they understand the order of the steps, the deliverable dates for the steps. So kind of breaking things down as much as possible and working with them to identify sort of a plan for each of those steps. And again, some of this is just sort of good organizational steps in general, but they're particularly helpful for people that have some of these kinds of challenges. Then we can talk about communication in the workplace. Again, because there are some challenges in organizing, perhaps in auditory processing, writing and dysgraphia, sort of the written expression. It is important to be very clear in communication, to have written job instructions, written job descriptions, and written job instructions. being very clear about the expectations and the consequences of meeting or not meeting those expectations. And so in doing so, it would be not just putting things down in writing, but it would be working with the person, going through them very clearly so that it's clear that the person understands them. Having consistent regular meetings to set goals and review progress. Again, not a bad thing to be doing in general, but something that in particular for people that have some of these challenges can be very helpful. Developing strategies in advance to deal with conflict should it arise, and then evaluating the effectiveness of the accommodations and strategies that you have been using and putting in place so that they can be moderated and modified as you go along. You don't want somebody to kind of be struggling for a long time, feeling that the accommodations or the strategies that are being using are really not helping them, and then not then being able to be effective in their work. So it's a lot of sort of checking and setting things up so that there is a monitoring in a way that is done helpfully and kind of not overdoing it, but doing it in a way that is helpful and both agreed upon by both the person needing the accommodations, and the supervisor or the mentor or the people that they're working with. So those are some of the challenges and strategies that can be used in the workplace. Let's talk for a minute about TS and law enforcement, interaction and de-escalation. So something that we don't often think about is what happens, we can't anticipate every single situation and every single setting, but we don't often think about what happens if somebody has to engage with with law enforcement. We have heard many situations where somebody may be pulled over, somebody with Tourette's syndrome may be pulled over for one reason or another, or have cause to engage with law enforcement in some setting. And people really don't understand what Tourette's syndrome is. They don't understand what these behaviors are that they're engaging in. And they can be often, these behaviors can be mistaken as actions associated with drugs or alcohol or some other, even other mental health disorder, some kind of psychotic episode or something. So it's important, and one of the groups that we go out and speak to is law enforcement, police officers, and other members of the law enforcement community in different counties and different towns, to try to, again, create that awareness so that they'll be a little bit aware if they see something that looks like Tourette's syndrome. So again, for most of us, if we get pulled over or have some kind of encounter with somebody in law enforcement, for many people, it creates anxiety and stress. Think of that somebody with Tourette's syndrome that may be engaging in these behaviors, how stressful it will be for them, and the possibility that it will exacerbate their tics and their symptoms. So under those conditions, they may not be able to make direct eye contact. They may be agitated, nervous, behavior might be a little bit erratic, and it might appear to be disrespectful. Again, this may be part of just the exacerbation of their symptoms. It's possible they might have difficulty understanding. They may be not able to stand or sit still. There may be a lot of movement. It's important when dealing with people under those circumstances to try to maintain neutral facial expressions. So as a police officer, for example, to try to maintain a kind of a neutral posture and avoid sort of getting in their face and pointing and finger shaking. Those are more kind of threatening kind of gestures and experiences, which are likely to exacerbate the stress and exacerbate the tics. You want to try to use non-threatening gestures, avoid touching the person. And as we said, the ticking behavior and the symptoms of these disorders can often be mistaken as behaviors associated with drugs, with alcohol, with other mental health disorders. So it's important, just to sort of keep that in mind. So for example, imagine if a young adult gets pulled over by a policeman for some kind of traffic violation, and that person happens to have coprolalia, and they start, they're stressed and their symptoms get exacerbated, and they start shouting out obscenities or some kind of other inappropriate language. That's likely to, at the policeman, that's likely to be misinterpreted and misunderstood as being disrespectful, as possibly somebody being under the influence of some kind of substance. So it is important to recognize these kinds of behaviors and try to do things to kind of de-escalate rather than to engage in behaviors that may exacerbate the situation. So again, in terms of law enforcement, you want a police officer to communicate that they're there to help, to try to be aware of the symptoms where possible and look out for them, to be patient and listen, and again, to let the person tick. If you are come to the realization that the behavior that they're engaging in are tics, let them tick. Don't ask them to stop. That usually will exacerbate the tics. If possible, again, if we're talking about a situation where somebody is, let's say, pulled over, if it's possible to turn off the lights and the sirens on the vehicle. As we said earlier, sometimes people have sort of heightened sensitivity to some of these sensory stimuli, and that might include something like the lights, the sirens on a police vehicle. And again, we understand that it may not be possible to turn them off, but where possible, we recommend trying to do that. Not responding to insults. So again, in the example with somebody that has coprolalia and is shouting out inappropriate things, not responding to them. And then again, that use of non-threatening gestures and giving choices to the person where possible. We have produced wallet size and a little bit larger size identification cards for the glove box or for your wallet that identify the person as having Tourette's syndrome with a brief explanation of what Tourette's syndrome is. And we encourage our young people, even adults, to have these in their wallet, have them in the car, and use them in a variety of situations, not just in encounters with law enforcement. If anybody is interested in these, we'd be happy to send you some. And again, there are really a variety of situations where you might want to use this, might want to identify yourself. We're talking about it now in terms of a law enforcement situation, but there's lots of situations people might go to a movie theater. And again, imagine what it is like going to a movie theater if you have Tourette's syndrome. Sometimes people plan out very carefully what time they go. They'll go at a time when they feel that there aren't going to be a lot of people there so that they won't disrupt them. But that might be another situation where you might want to carry this in your pocket and, show it to people if there's any kind of conflict that occurs based upon somebody's tics being deemed to be disruptive. So I think it's important for people to have some kind of way of identifying themselves as having Tourette's syndrome with a little bit of an explanation. Can be used in a variety of settings. And then finally, Tourette's syndrome in private practice, hospitals, and other settings. Just a few brief words here. Many of the strategies that have already been mentioned can be applied in, in a variety of different settings. So education, as we've said, is key. You always want to educate. You want to become educated on what Tourette's syndrome is. You want to educate the people around the person with Tourette's syndrome so that there is a clear and full understanding of what it is, so that there is a context for understanding their behavior, whether it's the tics or whether it's the comorbid behaviors. As we have said, assess what is most distressing and most disruptive for that person. It may or may not be the tics, and it's going to be different for every person. So it is important, again, to use what you know in terms of working with somebody, but to recognize that it's not a one-size-fits-all kind of approach, that every person that you see or work with Tourette syndrome is going to have a different presentation, is going to require a little bit of a different way of working with them. You want to also take a look at the psychological stressors that accompany TS. So again, what are the anxieties that get triggered for the person, the stresses that get triggered for the person as a result of having TS and the comorbids. Social skills training, which we mentioned before, working with the family, of course, particularly when there are children involved. Addressing the environmental triggers, so helping people to, again, sort of set up their environment in such a way as to reduce the triggers for them. And then some of the approaches in terms of a, let's say, a private practice setting, CBIT, which, as I said, is a treatment for which training is required. If anybody is interested, we are always hoping to have more people in the state that are trained in CBIT. So if anybody is interested in learning how to do that, please let us know. And then CBT and exposure and response prevention treatments as well, particularly for OCD. And then, as I said earlier, we want to encourage people to develop self-advocacy skills, to understand their own Tourette syndrome, to understand the impact that it has on them, and to understand sort of what their needs are, and encourage them to develop the skills to advocate for themselves in whatever settings they might find themselves in. And that could take different forms. People might do that in different ways. One of the things that's also important when you're talking about Tourette syndrome is to ask the person how they would like you to respond to their Tourette syndrome, because it's not the same for everybody. Some people want you to just ignore it and not mention it. Some people find the behaviors they engage in to be funny and amusing, and that's how you can laugh along with them. Some people, it's very serious and they want you to just step away, let them tick, and then move on. So every person has a different way of kind of managing their tics and a different way that they want people to respond to their tics. So it's very important when you work with somebody with Tourette syndrome, or when you engage with somebody with Tourette syndrome, to ask them specifically how they want people to respond to their tics. It's going to be a little bit different for everybody, and then the way people self-advocate, the way people learn to speak up for themselves, is going to be slightly different for everybody based on their situation. But it's important, if you're working with someone, to encourage them to and help them to develop those self-advocacy skills. So again, just important that kids don't want to have TS. They don't want to be embarrassed by it, and they want to learn ways to manage it, and ways to accept it and embrace it. And so we must see the child as someone who is in trouble, who needs our help, not as someone who is the cause of trouble. And finally, I would like to just kind of sum up with a few points. Again, it's important to remember that people with Tourette syndrome are people first. So we don't want to identify them by their Tourette syndrome. They're people that happen to have Tourette syndrome, just like we would identify someone with schizophrenia as a person that happens to have schizophrenia or any other kind of disorder. We talk sometimes about ignoring the tics, not the person. Again, sometimes depending on what the tic is, it's more difficult to ignore it. But you want to make sure that we treat people with respect. Again, recognizing the tics, learning from each person how they want their tics to be responded to. So in as much as possible, trying to ignore the tics, not make not exacerbate them, not make a big deal about them, but acknowledge the person and be respectful. It's important where there's medication or other kinds of treatments happening to monitor them. Medication always needs monitoring. Any kind of treatment should be monitored. But again, particularly when we're talking about kids, young people, their growth and changes in metabolism might bring about a need for adjustments in their treatment, adjustments in their medications. It's important to pay attention to that. As we've said earlier, we don't want to ask people to stop ticking. We want to let them tick and give them the opportunity to calm down. And along with that, understanding that tic behavior varies in length and complexity, and we can't, kind of moving along and say, oh, hurry up and get that tic out. We can't resolve things in a set time frame. Every person is different. We need to respect that and let people have the space and the time that they need to tick and to calm down. Reinforcing good nutrition, sleep, leisure habits. Again, we know that somebody who is tired is going to tend to exacerbate the tics. So we want to just reinforce sort of good hygiene, good, basic living skills behavior, because that, we know that will help somebody just in their general kind of day-to-day functioning and management of some of these symptoms. It's important to recognize, again, that TS affects not only the child, but the entire family. And as we said earlier, it affects people in all spheres of their life. So there are psychological and social components, emotional and physical components. And by the way, I don't know that I mentioned it earlier, but depending upon what the tic is, it can be very physically, emotionally draining and very physically draining and exhausting. And at times there can even be tics that can cause self-harm and self-injury. So we really are talking about things that can be very significant and really have a strong and significant impact on people's lives. Remembering again that symptoms may look like they are controllable, but they're really not. As we said, people can sometimes suppress for a short period of time, but there's a consequence to doing that. Flexibility, creativity, and out-of-the-box thinking are really key in terms of developing accommodations and approaches to working with someone with Tourette's syndrome. And overall, we want to think about the goal as helping to manage the symptoms and minimize the distress and disruption to the person's life. Again, there's no cure. Any of the treatments are really around managing the tics, managing the kind of stresses and strains and the emotions that go along with the tics, and the comorbidities. So we're not talking about anything to kind of completely take away the tics. We're really talking about how to manage them so that the person can have the least disruptions in their life and function to the best of their ability. So with that, that ends the webinar. I thank you very much, and have another opportunity for questions.
Thank you so much. We have a couple of questions. For clarification, you said that TS is a lifelong disorder.
Yes.
What are some of the symptoms in adults without tics? Is it more neurological?
Somebody could really be asymptomatic. They could really have no symptoms. There are no really real manifestations of it, but it could return. It could reemerge, so that it's not something that is ever sort of cured. We tend to, as I said, refer to it as a lifelong disorder because there can be periods where it can kind of reemerge for the person. Also, the comorbidities tend to remain more symptomatic in adulthood. So even if somebody, if their Tourette's syndrome is not apparent and symptomatic, but they have comorbidities, they have ADHD or they have OCD, those will tend to continue more into adulthood.
When you said that symptoms and tics can reemerge, is that usually caused by anything?
again, it could be certain stressors in their life. There's no sort of singular thing that would necessarily trigger it to reemerge. And for some people it may, and for some people it may not.
Thank you. You mentioned some specific accommodations regarding in the workplace for anxiety, concentration, organization, and communication. Are those recommendations from the ADA, or is that something that you found over your time researching this?
A number of them came from the Labor Department. So it comes kind of from some different sources. It's not from the ADA directly. Many of them do come from the Labor Department.
All right, great, thank you.
I guess I'll just add, I don't know if people have access to the slides. Some of those slides do have an attribution, I believe, on the bottom, of a reference to the Labor Department, so where it came from. So you could, if you're interested, you could, you could go to that that site.
We will be sending out the slides after. All right, so
yes,
I think
it should be noted on one or two of those slides, so that would be a reference that you could use.
Okay, great, thank you. Is there anything else you'd like to add?
I don't think so. I appreciate everybody's attending the webinar. If anybody has questions down the road that come up, please feel free to reach out to us, and please feel free to use us as a resource. We'd be happy to send you any of the those glove box cards or any of our basic information, our flyers, brochures. If people want to keep them in their offices, or have any reason to have resources related to Tourette syndrome, we'd be happy to speak with you. We'd be happy to provide you with that.
Well, thank you so much. This was great and very informative and fascinating. Very interesting subject.
Okay, thank you again very much for the opportunity, and feel free to reach out. I appreciate everybody's time, and enjoy the rest of your day.
All right, thank you. The post test will be, the URL will be sent out over the chat, and then you will also receive an email later on today with the instructions. All right, have a great day, everybody. Thank you.